All right, let's get going here, guys. So today we're going to go over some hormonal information. I deem this to be pretty important information. I mean, this stuff comes up over and over and over again. I mean, if there's probably one area that in functional medicine that gets just beat up pretty often and just rehashed over and over and over again, and that there's also probably more opinions about than you can count, it's hormones, right? And honestly, I'm not going to really differentiate from that mindset today. What I'm giving you is pretty much my opinion and my take on it from what I see on a day-to-day basis. But hopefully, as I go through this with you, you'll see why I've kind of come to the viewpoint that I have about this, because I feel like I'm trying to use science to get to that background or to get to that point. But let me go into some of the background with you, and it'll make sense as we go through. So what are we going to talk about here? Well, I want to review what the roles of the hormones are, because if you just look at, let me just take an example here, like let's just say testosterone. If you look at, well, someone has low testosterone, you don't really think about all the things that go into why someone has low testosterone, then keeping that testosterone from being low again in the future is probably not a very likely scenario, because you probably haven't fixed the underlying dysfunction that created it in the first place. We want to look at what the importance of the hormones are. I'm going to challenge your ideology a little bit on that and have you think outside of the box for why typically we think about hormones. More times than not, our mindset here is that it's going to be something revolving around the sex characteristics of the body. The roles of hormones are far, far beyond that. Far beyond that. Okay. We want to understand the process of steroidogenesis and the steroidal hormone pathways. I'll give you some examples of that. And really think about these things as a flow chart and an algorithm. And when you're talking to the patients, if you just will take the time to memorize these flow charts that I'm going to give you, just one of the steroidal hormone flow charts, and literally when you look at these tests or when you're listening to a patient, if you can just start plugging in on that flow chart where things should be going and where things aren't going, you'll have a good mastery of the hormones. And honestly, that's one of the mistakes that I see a lot of other clinicians make, is that they try to single out a hormone, and you can't single out hormones. It's impossible. They're too interrelated to each other. We'll look at the diagnosis of hormones. That's kind of a little bit of a controversial topic, but we'll add some common sense to it, because I think that's what you kind of got to have with this. Some of the endogenous influences on the hormones. So we talked last month about detoxification. So that's a big one as an example on this. We'll talk about reasons that you would increase hormone production. So if you just think about hormones in terms of whatever the steady state of the hormone is, are you producing too much or too little? And if you're producing too much, why are you producing too much? And then why are you not excreting it out? Or if you're too little, why are you too little? Why are you not producing enough? We'll look at some schools of thought on some treatment options, and then I'll finish this up with giving you some of the mistakes that I've made and how not to make those same mistakes when you're approaching this, okay? So let's look at the roles of hormones. Some of this is going to be pretty common sense to you, but again, we want to kind of set the stage here, because part of the reason that I'm giving you the roles of these hormones is so that when you're interacting with your patient and you're doing your initial history intake with them, you can set up your line of questioning along the lines of what the function of some of these hormones are to get better insight into what those levels might be for that patient. So cortisol. So cortisol gets a bad rap unfairly, right? Everybody looks at, well, cortisol is what's going to put fat around my middle, and sometimes I'll talk to patients. I actually just saw a new patient yesterday, and she said, I just briefly mentioned something to her about having low cortisol, and she said, well, I got all this fat around the middle right here that I've been putting on, and I thought that was associated with high cortisol. Well, there's some commonalities between the highs and the lows, so it's not just high or just low on this, okay? The truth is that by the time most patients ultimately get to us, they're in a more of a chronic scenario. They're not in that acute scenario. Elevations in cortisol, when we do see those do pop up from time to time, but that's more of an acute presentation. That's not your chronic patient or your chronic hormonal deficiency there. They're producing the adrenal gland. That's one thing that most people know about cortisol with this, especially in the functional medicine world. But I think the part that really is not emphasized enough with cortisol is the fact that it's a glucocorticoid. And that is, if there's anything on this slide that you want to hone in on, it's the fact that it's a glucocorticoid. And really, when you're thinking about this, it's the fact that as that glucose starts to drop, your cortisol has to kick in to bring that back up. So, and I'll talk more about this in some of the symptomology stuff, but if patients are complaining about hypoglycemia, or if they give you that immediate, hey, I get tired 2, 3 o'clock in the afternoon, first thing you should be going for is what's causing the hypoglycemia. Is it just lack of eating, or is it that they don't have enough cortisol available to bring that back up? And it's, even if they're not eating frequently, the cortisol, even if they miss a meal, should be able to kick in enough to keep that glucose level up. Right? The next one here, the anti-inflammatory effects of cortisol, most of us all know that. That's the whole, you know, it really doesn't matter what specialty of medicine you're in, whether you're thinking along the lines of something like prednisone or even the corticosteroid injections, those types of things. I mean, we kind of all know the anti-inflammatory effects here. And then the immune suppression. So again, let's go back to what cortisol is actually doing is it acts as an anti-inflammatory. So these cytokines that actually stimulate the increase in the B cells that are going to drive these immune responses. Cortisol actually down-regulates the production of those, or it shifts the production in those. So think about this in terms of what we do in day-to-day clinical practice. In clinical practice, we're telling someone, hey, you have a food allergy, right? And that food allergy is manifesting itself because you're also, or your symptoms are manifesting because you're also, your immune system is reacting against a tissue in the body. So the way we go and check that is we look for antibody production. Well, essentially, and those are going to be derived from your B cells. Essentially, what's happening here is that prednisone or any of these other anti-inflammatories are suppressing that production of those antibodies or of those other B cells. So think about that when you're doing the different tests, when you're ordering food allergy panels or antibody profiles, that type of thing, that if the patient's on any type of immunosuppressive drug, any type of cortisol mimicking type drug, that could be an influencer on the results that you're getting back there. So you don't want to give the patient a false positive on that. Or I guess that'd be a false negative, not a false positive. DHEA, again, another hormone produced in the adrenal glands here. And you're going to see very quickly in this, because I've got a diagram for you that differentiates where all of the two areas that the hormones are produced. You're going to see very quickly these adrenal glands are pretty important, right? So we kind of in functional medicine have known that for a long time, but it seems like it's only us in functional medicine that really pay much emphasis to this, unless you've got Addison's or Cushing's. Well, how many people are running around with Addison's or Cushing's as a percentage of the population? It's pretty slim. How many people are running around with some type of adrenal dysfunction? I always think about it like this. If you've got, let's say you've got a continuum, and you're in a normal ideal is right in the middle of the continuum. Over here is Addison's disease, and over here is Cushing's disease. To get from normal over to Addison's, what if I fall right here, and I don't really fall into the range of diagnosed Addison's? Am I normal? No, I'm not normal. I still have a state of dysfunction. So that's the reason we can't really just go based on what traditional thought is on that. There's a state of dysfunction that comes along with these. I diverge. Your DHEA, most abundant hormone in the body. So it must be important in the fact that it's a precursor. And that's the way I want us to think about DHEA. It's a precursor. It has to go to other hormones. And those specific hormones, based on where these pathways fall out, are going to be your androgens. You can get into your estrogens through this as well, but it's going to be the androgen. And it's going to have an anabolic effect. Estrogen. So estrogen is going to be, now we're thinking about ones that are produced in the sex glands. So your estrogen is going to be produced in the ovaries. Secondary sex characteristics. The way I want you to begin to think about estrogen, though, and this is the part of it that becomes clinically relevant, and this is how you can begin to decide which hormones you need to start pinpointing and beginning to focus on, is that estrogen is going to have a propensity to increase fat and water in the body. So if you see that you've got some type of unexplained reasoning for that, this is one of the things that you want to start popping up with. Another thing that estrogen is pretty responsible for is increasing coagulation, platelet aggregation. So think about the numerous markers that we have available to us that show increases in clotting mechanisms. All your inflammatory markers are going to be associated with that. Your LP Little is associated with that, and just platelets. Platelets by themselves. If those platelets, they don't have to get to that 400, 410 mark. If they're starting to cross above 250, then you're beginning to think, hey, there's probably some excess mechanisms here that are causing these platelets to begin to adhere a little bit more readily than what they should under an ideal scenario. I always think about this when I talk to patients, the example I'll use with them is, do you remember the Yaz commercial or any birth control commercial you've ever heard, and you get to the end of it where they're spitting off all the symptoms at 110 miles an hour, right? There's a part in that that always says with the birth control, if you're a female, you're over the age of 35, and you smoke, you probably shouldn't be taking birth control. You should talk to your physician about it, right? This is the main mechanism behind that. And if you look at what birth control is, birth control, with very few exceptions, are estrogen mimicking hormones, right? So, and fluid balance is the other part here. So that's your water retention, water holding aspect of that. Now, in what we typically think about in contrast here is going to be your testosterone. You're going to see some of the exact opposite effects are going to be associated with testosterone. It is your secondary sex characteristics in the male, but you're going to get increased muscle tissue development. So as in opposition to increased fat development, increased muscle tissue development. So maybe if you've gotten to the point where you're saying, okay, I do think that there's an increase in estrogen here, I need to look a little bit more into that. You also want to follow up and say, well, if I get the estrogen down, what if I don't bring the testosterone up? If that's part of the scenario for this patient, if you're only bringing the estrogen down and you need to pull the testosterone up, you really probably aren't going to make much difference in their body composition on this. So both sides of this. Increase in bone density and regulates platelet aggregation. So again, just kind of yin and yang there. This is our last background slide on this. So your progesterone. And you could also, and I did it a little bit different on this slide, I kind of gave you the dichotomy there between estrogen and testosterone. There's also the dichotomy between estrogen and your progesterone too. So you got to think about both of these, and this is the reason I say that all these hormones are very interactive with each other. So with progesterone is produced in the adrenal glands, but in cycling females, you're also looking at the corpus luteum here, and that's the reason you get the changes in the menstrual cycle. Basic role, supportive pregnancy, and it's going to relax smooth muscle tissues. Maintain stem cell activity. So if you think about this in terms of someone who is, let's think about it from a musculoskeletal viewpoint for a minute here. If you've got someone who chronic joint pain, chronic bone pain, things like that, or they don't really heal very well, the fact that they don't have chronic stimulation to the stem cells to differentiate into these other types of cells, this may be part of the reason that patient's not really healing all that optimal. Okay. That's the reason we can't really isolate one area in the body. It's kind of that reductionist viewpoint. It's not very effective most times. And then progesterone also has some anti-inflammatory properties, but granted, they're nowhere near to the extent of what your cortisol-based anti-inflammatory is going to be. And then aldosterone, this is one that I never really have understood why the labs don't put this in with the panels, like the salivary labs. I mean, they're looking at pretty much all the other steroid hormones. It seems like it would just make sense to throw this one in there too, because you have to think when you're looking at the chemistry profiles and some of the shifts that are happening in those electrolytes, you're going to have changes with the effects on the sodium, on the effects of the potassium, and just water balance in general. So with aldosterone, it's going to fall into the category of what's known as a mineralocorticoid. So basically trying to balance out predominantly your sodium and potassium, but you do have other electrolytes in there. But if you get patients that tell you, hey, I drink a ton of water and I'm still thirsty, or I drink a lot of water, and you run their total body water percentage and you're not seeing that shift to any significant degree, this has probably got something to do with that. But again, you can run a blood level on this, and it's decent. It's not bad. It'll get you in the ballpark, but I think a salivary level on this would probably be a little bit more ideal. But again, nobody really tests that. So that's the background there. So now let's look at that was the traditional thought process on this. Here's our non-traditional thought process on this, and this is so much of the reason why I tell you that hormones cannot be looked at in the traditional viewpoint, and we've got to think about the mechanisms of what they do outside of just sex-related characteristics here. So if you look at these first three hormones here, the pregnenolone, progesterone, and DHEA, if you're not familiar with this, you'll see it when I put the flow chart up here. These are far upstream hormones. I mean, these are your more upstream hormones. They haven't differentiated down into your in-stream hormones yet. But the bottom line on this is that these actually have physiological roles too. We can think about things like progesterone and DHEA. I just gave you what some of those were, but most people only think about pregnenolone as its role as a precursor to other hormones. Well, pregnenolone, if you look in the literature on this now, actually has physiological roles on its own. There's things that it's doing by itself too. And then you get in between some of these hormones with these conversions, you get something like this allopregnanolone produced. And that's actually going to be an intermediate in between these hormones, but it has a physiologic role as well. It actually has a calming role in the brain. So when we talk about, let me just use a real quick example for you. You know, when a female, if you think about in terms of PMS, one of the characteristics of PMS can be irritability, right? So if you look at what's happening there, you're starting to get to the point where the estrogen levels are coming up. So if you don't have the balance of the progesterone to compensate for that, then you get too much neurological excitability associated with the irritability, and you don't have the calming nature of progesterone to offset that with. So that's just kind of looking at, and it's these metabolites that are actually having those neurological effects and stimulating those neuroreceptors. But here's something else that I thought was pretty interesting in looking at this. It's synthesized in the central nervous system. So these things aren't necessarily synthesized in the adrenal glands or in the testes or ovaries. They're actually synthesized at the site of function. So where they're going to be used at, that's where they're going to be synthesized at. So that's kind of a whole different mindset around what we've kind of traditionally thought about with regards to hormones themselves. And it's so much of, if you look at so much of the things that we all see on a day-to-day basis and ultimately where they can end up, there's this huge contribution of the inflammatory process, and we know that one of the main things associated with inflammation is decreased neurological function. If you ask your patients, hey, how's your memory, how's your motivation on a day-to-day basis, most of them tell you, my memory, it's not quite as good as it should be right now, right? Or my motivation's not as significant as it has been in the past. Those are all indications of neurodegeneration. So if we look at some of the other things that these neurosteroids are going to also do, increased synaptic function, myelination, regulation of neuron cell life. So this is what's going to offset that neurodegeneration, and it's why those hormones have to be present in adequate levels, but not too much, right? There's a balance in this. Trust me, there will not be a test on this. I really put this diagram up here to just kind of show you the interplay. If you want to go read more on this, there's a citation for you. But really my point behind putting this slide in was to show you the actual mechanistic role that the neurosteroids play as it relates to the gonads, and then how they all cycle back around to each other. So just to show you that there is an interplay with this. I do want to take the time. I thought this study was pretty spot on. I mean, it was pretty straightforward. So I do want to take the time to actually go through this one with you. If you look at what this says, neuroactive steroids refer to steroids that are capable of regulating neuronal activity. So again, we don't typically think about hormones or steroids as being associated directly with neurological function, but they are. The neuroactive steroids synthesize either de novo in the nervous tissue or in the peripheral endocrine glands. So that must mean if they can be synthesized in the peripheral tissues and in the central tissues, that they have the ability to cross that blood-brain barrier, right? So have exhibited numerous important modulatory effects on brain functions and brain diseases. Again, we're going to talk about the neurotransmitters, but I want to use this as kind of setting the stage for why we have to look at this as we're looking at the neurotransmitters, and looking at either one of those two independent of each other is kind of setting you up for failure as well. You're probably going to miss something if we do that. So we want to look at both of those. And then this also goes on to say, at the cellular level, in addition to the effect of postsynaptic receptors, most neuroactive steroids, including, and this is really the reason I wanted to put this up here for you, is to show you how many different things there are related to this. Pregnenolone, pregnenolone sulfate, progesterone, allopregnanolone, DHEA, your DHEAS, testosterone, estradiol, all of those have modulatory effects. And then look what it goes on to say, have modulatory effects on the release of multiple neurotransmitters, and that's pretty much all of your major neurotransmitters right there. So they're directly related. I mean, that particular, and actually they go even one step further in the things that I was just saying: memory, emotion, motivation, motor, and cognition. Right? So those are things that you have. Those are subtle indicators that if you just ask your patient, you'll know right away that they've got some type of hormonal imbalance that you need to be thinking about with them. Just to show you how relevant this is a PubMed. I just ran neurosteroid. There's more than 1 million citations on PubMed, so it's kind of important. Right?
Wow.
There's not many things you're going to go type in just a word like that and get 1 million citations for. And yeah, we never hear about it, right? We never hear about neurosteroids. So this hormonal importance. If you guys will take these next 2 slides, and when you're looking at these hormone profiles, if you run a hormone profile on a patient, or even when you're still in the history portion of the process, if you take these next 2 slides and use this information for yourself and in the explanation to your patient, you will be able to have a real firm handle on hormones. Okay? So here's what it boils down to. You've got this balance between anabolic and catabolic, between build up and breakdown. And hormones pretty much fall into one of those 2 categories. So if you're increasing your catabolic state, you're increasing tissue breakdown, you're increasing inflammation, you're increasing degeneration, and you're decreasing the anabolic effect, then you're looking at rapidly aging, or you're looking at rapidly increasing the aging process. So if you're thinking in terms of we're trying to do things that are anti-aging with our patients, things that we've talked about, telomeres, things that are trying to maintain the length on those telomeres on the ends of those chromosomes, this balance for the hormones between anabolic and catabolic is why that is so important. Okay? So this is very crucial. And something I've yet to say, but I'll go ahead and lead into it with this. Hormones are chemical messengers. You got the wrong message going out, you're going to get the wrong message going to the next tissue that needed the response from the hormone. Right? Now, that's slide 1. Slide 2, your progesterone and estrogen. And actually, most of the labs, not all of them, most labs will ratio the way that they ratio on this slide is cortisol will be the catabolic, DHEA will be your anabolic, and they ratio those 2, right? Your progesterone and estrogen, they typically ratio these as your progesterone or P4 and your estradiol or E2 is typically what you're looking at. But the reason that this is so important, and you can ask questions around this as well, estrogen, when it increases, is proliferative. It's going to stimulate estrogen-related tissue to become overactive. Right? That's the whole connection. For an example, that's the whole connection for estrogen as it relates to breast cancer. Right? It's overstimulating of that tissue. And then your progesterone is going to be anti-proliferative. So if you're dropping your progesterone, your anti-proliferative characteristics, and you're increasing your proliferation, you're skewing the mechanisms that are happening in the body. You're setting that tissue up for some type of degenerative state. If your tissue is trying to replicate at a faster and faster pace, apart from what is considered ideal for it, the likelihood of making a mistake in that replication process has greatly increased, right? And then you stack everything we've talked about before on top of this with methylation, detoxification problems, and now you increase that risk even greater. Same bottom line on this. Wrong message in, wrong message out. So here's what you got to memorize, and I'm not kidding about that. You need to go find a flowchart on this and seriously memorize this. And if you can memorize the concept of what I'm going to show you here, you will have hormones down. So let's just point out the big ones on this. You're going to start up top with your cholesterol, and then you're going to move into your pregnenolone. And then pregnenolone is going to differentiate out into DHEA over here, and then your progesterone. And from your progesterone, you're able to move down into all of your cortisol-based pathways and aldosterone. And then over here, you get into your androgens, actually your androgens right here, and then your estrogens over in this area. But here's what you can glean from this slide, and this was the importance of what I wanted to point out. You've basically got 2 areas of dysfunction as far as tissues that you're thinking about in the body. You're either thinking about the adrenal glands or you're thinking about the gonads. So, you can you can have that as it relates to the menstrual cycle. You can begin to think about the corpus luteum and those types of things. But just think about the adrenal glands and the gonads as being your primary target tissues on this, right? Just basic physiology, anatomy and physiology is all we're talking about here. Now, here's something else I want to show you. Cholesterol. And the reason I'm bringing this up is that this is going to set the stage for what I'm going to talk to you very briefly about bioidentical and synthetic. Pretty much all of us in this room are going to be on the side of bioidenticals. I mean, it just logically it makes sense to us, right? But scientifically, here's the reason that that's important. If you look at the basic structure of cholesterol right here, you can see this basic backbone. Notice those 4 rings are consistent all the way through every single one of these hormones that we've talked about. It doesn't differ. The only thing that changes are going to be these side chains out here. And it's mostly on this carbon, coming off of that carbon, and right here. Those are really your only differentiating points on that, okay? Here's something else that's kind of cool if you really want to look at the kind of the chemistry aspect of this. If you look at your progesterone-related chemicals, they all have 21 carbons. If you look at your androgens down here, they all have 21. Estrogens, 18, and then your cortisol-based structures are going to have 21. That's 19, I'm sorry. But you can see the similarities between these things, right? There's very subtle differences in these. My point being on this is that when you take a synthetic and you introduce a synthetic in here, the synthetic has been manipulated at one of these bonding sites right here, or one of these carbon molecules, and then the side chain is different. That's how they're able to patent that, right? But look how, the point is that look how close these structures are, and yet the difference between, I don't know, let's just pick progesterone and estrogen down here are very significant. But the actual structure is really not that much different, right? So what you're doing is when you introduce a synthetic hormone that has a side chain that's not inherently recognized by the body, you're not guaranteeing that particular hormone is going to interact with the appropriate receptor site like it should. Okay? If you put the wrong hormone on the wrong receptor site, you either don't get the message you're looking for or you get too much of the message you're looking for. This is a very good chart. It actually goes into telling you the different enzymes, some of these cytochrome P450 enzymes that we talked about last time. It actually goes into telling you where all these enzymes have effects at. So that's a good chart. You actually get the actual enzymes themselves in here as well. Now, let's think outside of just the adrenals and the gonads for a minute, all right? Because those glands don't act in isolation either. They've got to have influences going into them. So if you look at, and I'll show you why this is important, because you can use this piece of information with your standard labs to actually suggest to the patient, hey, you need to follow up with your hormone testing. So if you look at your ACTH, ACTH is going to go up to increase cortisol production. Okay, most of us know that one. And then your FSH, I'll show you a little trick on this FSH here in a minute. For females, that's going to, if you think about your menstrual cycle, that's going to be your follicular phase. It's also going to stimulate your estrogen, right? There's not a significant increase in FSH compared to LH, but it does increase to stimulate that process. Now, in males, the way that I remember this is I kind of cheat with this. There's an S in FSH, there's an S in Serotoli cells, and there's an S in sperm, right? So FSH stimulates the Serotoli cells to produce sperm. So your spermatogenesis is driven by FSH in males, right? Now, LH, in females, luteal phase, you get more of a spike and you increase the production of progesterone through the corpus luteum. Your males, Leydig cells and testosterone. Okay? And then just kind of L and L on that. Make it simple for yourself. Now, here's what's important about this. This is the reason that last slide is relevant. Most of us are getting some type of thyroid assessment with new patients. It may not be, down to free T3 and free T4 and reverse T3 and all the intricacies of thyroid hormone, right? But at a bare minimum, you're going to have a TSH available to you. If you look at the production of TSH and you look at the anterior pituitary is a very unique gland. It has the ability to produce multiple hormones from the same site. And if you think about it, if you back out for a minute and take that piece of knowledge and you say, okay, now let me look at our average patient. Our average patient is under more chronic stress than what we would consider to be ideal for them. So that means their cortisol levels are going up. As that cortisol level goes up, that feedback loop going back to the brain gets dampened. So that production of ACTH, actually CRH from the hypothalamus and then down to the pituitary to produce ACTH, that whole process gets blunted. In that blunting process, you're also going to blunt the production of TSH, FSH, and LH potentially. So when you're seeing that a patient has lower levels of TSH, but yet they have a normal T4, because that's in dichotomy. Both of them, if one's going low, the other one should be going high and vice versa, right? They shouldn't be normal and TSH dropping low. So if you're seeing the TSH come down, then that's an indication you might want to follow up with the hormone, specifically, if nothing else, looking at a cortisol-DHEA ratio to each other, because that patient's probably in some type of sympathetic overdrive response. But it all boils down to, mechanistically, all those hormones are produced from the same region in the anterior pituitary. So lab evaluation of hormones. We want to have some type of documentation for why we're making the decisions we're making. So here are just some of the differences between this. Again, this is one of those things that, depending on who you ask, you're going to get some people that are just, you know, the serum levels are the end-all be-all. Saliva doesn't exist. Saliva is still hooey, and there's no science behind it. And yet there's, you know, how many studies out there in the literature on saliva now. And same thing with saliva. If people will tell you saliva is the only valid mechanism, they all have their pros and cons, okay? So don't get so hung up in that fact. Just learn what the pros and cons are and learn how to use the test in the scenario that you're in with it. Where you're going to have some important key points with the blood and serum is going to be in your free and bound fractions. You actually have to differentiate those two things with your serum testing. And from my experience, I think the testosterone and the pregnenolone are actually pretty good markers in serum. Estrogens, I don't have a lot of comfort, honestly, in looking at estrogens in serum. I don't think they match up to the characteristics most time of what the patients are saying. Progesterone kind of falls in that same category for me. Ombra's pregnenolone, this is one that I'm using more and more recently. And the point I'm trying to make to patients with this is that I don't like seeing my patients under 80 on pregnenolone. If they're under 80, then it's an indication for me that they don't have the precursor to continue to drive that steroidogenesis. So they're limited in their ability to even begin to make these hormones. So that's an indication that I probably need to begin to think about utilizing pregnenolone to support their therapeutics. Right? So 80 is your cutoff on that. In your saliva, you're only getting the free fraction, and one of the advantages to saliva that really nobody argues about with this is the ability to assess the diurnal pattern. Cortisol is a variable hormone. It's going to change throughout the day. We need to know what that curve is. Depending on what your curve looks like, it really dictates what the treatment outcome or treatment process should look like. So it really changes that. You can't see that in blood. A one-time stick in blood, even if somebody's willing to do an AM and a PM for cortisol in blood, it's not ideal. The only thing you could really pull away from that is to say that someone has a low level. But again, do you know that it's low at the time you stuck them, or is it potentially low then and high at other times during the day? You just don't know. So saliva benefits here. And then where urine where it shows its attributes is going to be in your metabolites. So with some of these neurosteroids that I had mentioned earlier, the allopregnanolone, those types of molecules, your estrogen metabolites like the 2, 4, 16s, this is where urine is going to have a better outcome on those types of markers. Now, what is really our best indicator? I mean, why do we even think that we should be going down this road with patients anyway? It's the history process. You got to ask the right questions, right? And this is something that I've kind of had to reiterate to myself at times lately, is when you get into these difficult hormone cases sometimes, and what you're hearing, the feedback you're hearing from the patient doesn't really match up with like maybe you've been in treatment with them for 2 months, and now they've gotten a little better, and now their symptoms are starting to change, and it's not, their labs probably aren't indicative of really where their state of health is anymore. You have to start going through and asking some of these questions, because it's still a little bit too early to go rerun another test on this, especially if you're looking at a saliva panel or something like that. So you want to kind of hammer down on some of these questions with them. These are some of the ones that I ask most frequently. There are multiple other ones. You can do long, expansive questionnaires. These are just the ones that I've found to be most indicative for me. So I look at with the menstrual cycle, what's the length? Are we regular or irregular? The flow, I want to know light, medium, heavy, heavy and clotting. I'm beginning to think more estrogen. Same thing with PMS. You can kind of run through those. With your breast tenderness, and there's no right or wrong on this. I tend to think with the menstrual related stuff, more estrogen. I tend to think with the breast related stuff, less progesterone. But again, it's a balance. It's not an absolute low progesterone or an absolute estrogen dominance. It's generally a balance in there somewhere. Of course, vaginal dryness and libido. Libido, mental clarity, brain fog, motivation, and constipation all going in with both sexes. And typically you don't think about the constipation, but this is a real big one you should ask for multiple reasons. If they're not getting, if they don't, let's use, in males it would be testosterone, lower testosterone. In females it would typically be low estrogen or excess estrogen, not allowing those receptor sites in the brain to function adequately. But if they're not getting dopaminergic activity to stimulate their bowels to have a movement, then they're going to be constipated, right? So you got to have those hormones, those neurosteroids to stimulate those receptors to get those neurotransmitters to work. Remember, that was the basis of what the outcome in that study was. And then the backside of this is that if they're constipated, then they're not clearing out their hormones effectively either. So you got to look at it from both perspectives on this. One of the things that I've started doing with patients with constipation is looking at doing things to support dopaminergic activity, whether I'm giving some type of straight dopamine support, whether I'm manipulating the hormones. You know, you may have to jumpstart them with doing something like some mag citrate or mag hydroxide or something like that. I mean, those things are still necessary. A vitamin C flush, you know, however you do that. But for the patients that this is a chronic issue for, think about those dopamine related pathways with them on the backside of this. Muscle tissue maintenance and strength. This actually goes for both sexes as well, so don't just isolate that one to males. And then one of the ones that I've put a lot of emphasis on lately is this hypoglycemia. Again, ask your patients about hypoglycemia. I probably literally find it in 80 to 85% of my patients have some type of hypoglycemia if you ask them the right questions on that. And most